Hi, everyone. Good afternoon. Thank you so much for coming. I'm Ashti, again, a hospital medicine doctor here at Northwestern and the co-director of the Center for Global Health Education. I know you were all enjoying the posters because I had to drag you back into here. So congratulations to all the great posters and the great poster presenters. They're really good. Every year they get better and better. I think we were very, very impressed. So congratulations to all of you, and thank you for taking the time to do it. I think your projects really showed, there were a lot of global health education projects, but there was advocacy, digital literacy, health promotion, public health, economy, agriculture, really cool stuff. So thank you all for sort of showing us the interdisciplinary nature of global health and sharing all of your innovations and ideas. So now we move into our speaker part of the program, and I'm very honored to introduce our first speaker, Dr. Wagaki Gicheru. Dr. Gicheru is an anesthesiologist, educator, and researcher based in Kenya for the past 24 years. She received a Bachelor of Medicine and Surgery from the University of Nairobi and practiced for some time before returning there for a Master's of Medicine in Anesthesia. She is a Canadian Point-of-Care Ultrasound Society Master Instructor, a Basic Life Support and ACLS Instructor, as well as one of the founding fellows of the College of Anesthesiologists of East, Central, and Southern Africa. For the past 20 years, she has been working at Kenya Medical Training College, which is where I met her, where she trains middle-level health providers in anesthesia and critical care. She's a health professions education enthusiast with a passion to see medical educators and faculty develop skills in the use of technology and simulation. At KMTC, she is the head of e-learning and the coordinator of the simulation lab. We started our partnership the way we always do, with a small project in health professions education together, and it's been very exciting to see the growth of health professions education, medical education in Kenya, and led by one of our very own innovators here with Dr. Gicheru. So I'm really excited to hear from you. Thank you and welcome. So you can use this microphone or this microphone. Okay.
Yes. All right. Okay. Good afternoon. It's my great pleasure to be here. I think listening to Professor Ashti introduce me, I was like, what? I think I'm really honored that she could give me this opportunity to come and speak and just share some of the things that I do. I will not. I must have a disclaimer to say that I'll be speaking about KMTC, but it doesn't mean that some of the things are things they do, but I might add my own opinions and thoughts. And I'm thankful also for the Institute for having me. I said this is me, and I think she's already read this. One of the things I like to do is simulation. So this was a simulation that we did on geriatrics. It was somebody else who had done the simulation, and then I was trying it out. And I actually found that I did not understand the challenges that geriatric patients face. My mother is 86 years old, and I literally experienced what she experienced. So they put these weights on us, and then you had something covering your eyes, so you've got no depth perception. I understood why she looks down when she walks and holds on to things, and going downstairs where she goes, why she goes down one at a time. So I think simulation, it has a lot of capabilities in terms of even helping us understand people in our communities and why they are the way they are. I'm talking about global health education, and I was looking at what does that mean. I think when for us, and I was saying this to the medical students, we don't really have a global health track. We do global health without knowing that we're doing global health. So I had to really think through almost to justify why I'm standing here talking about global health. And I found that, this explanation by Kaplan was that it's about issues that are transnational, that affect different countries. So I'm going to speak about one thing that affects our country and the world, including the USA, and that is workforce shortages. So we it is projected that by 2030, there's going to be a shortfall of 11 million healthcare workers. Okay, that could be some country's population or a city's population. So it is a prominent issue in the global front. It's a transnational issue when we're thinking about healthcare and our healthcare systems. And on top of that, it doesn't affect only the countries that we can say high-income countries. Unfortunately, most of the 11 million is experienced by low and lower middle-income countries. They have the highest shortfall. But the higher income countries are experiencing it, but they are able to increase capacity for training and also provide opportunities for migration. So migration is becoming our significant contributor to countries meeting that shortfall. In our country, we've had a lot of bilateral agreements with different, like the Arab Emirates, UAE, with other countries, the UK, where our Ministry of Health have signed these agreements that allow for health workforce to migrate. The countries that are most prominent, of course, is here, the USA. But other countries are the UK, and we do have bilateral agreements with the UK. It's Saudi Arabia, it's Canada, it's New Zealand, it's Australia. So there are quite a number of countries where people are migrating, and this is just showing the different. There were only 2 cadres that I picked from, and this is from the Organization of Economic Cooperation and Development 2025. And these are figures that they showed in terms of distribution. And you can see that it's a significant amount. You're talking about more than a third. Yeah. When I come down to Africa, Africa has got a workforce current projected that has been documented of 5.7 million, which has increased from 2018 when we had 4.3 million. So we are steadily increasing our workforce. Unfortunately, we have a significant number that are unemployed. It's close to 900,000 of these health workers. So we increase our health workforce, but a significant number are not trained. The other unfortunate thing is that it's been found, and this was recently released by the State of Health Workforce, a document that was produced by WHO, and they actually launched it early last week, that 62% are the ones who are able to have correct diagnosis, and only 40% it is evidence-based. So I guess the question comes in, okay, you're increasing your workforce, yes, but what about competence? What would we do about that? But looking forward into 2030, there will still be a shortfall, of course, because populations are increasing. So they're estimating that the shortfall will be 5.3 million. So there's a lot that we need to do about increasing workforce training as well as competence. I put the map of Africa so that you can see Kenya, where Kenya is. That's the country I come from, which is in East Africa. So now in Kenya, they recently, in 2023, there was published what we call the health labor market analysis. And in that labor market analysis, they found they recognized that they probably didn't have all the data, but at least from the data that they could find, they found that there were about 189,000 health workforce in 2024. So they probably have increased because now this is 4 or 5 years later. But this is at 30.4 per 100,000 in terms of the density. Okay, So it's way lower than where it's supposed to be, because in the SDGs, we are aiming for 44.5. Okay, so we are at 65% of the threshold of where we should actually be. And unfortunately in Kenya, we do have health workers who are unemployed, and we have 27,000 of them. And we are still saying that even though we have some unemployed, we have a shortage, and that shortage is only going to increase, because of course the population is going to increase. And it's projected to grow. As you can see, the health workforce has grown significantly, but we're still not able to meet the need that is needed. And here I just want to emphasize and show you the different colors. So the blue line at the bottom is medical doctors. So they're not increasing or growing as much as they should, or as would be desired. But you have the yellow-orange, that is mostly registered nurses. And those are nurses who are not trained at a degree level, so they are diploma level. And then you have the BSN is the slight blue that is coming up from somewhere in the middle there, that's above the purple. And that's because the BSN course is offered in the university, and they started it way later after the diploma courses. And then you have the green, which is enrolled nurses. So you see a big chunk of our health workforce is nursing. And then you have the orange that's at the top, which is clinical officers, who are equivalent to physician assistants in this country. So why do I say that, and why am I emphasizing those cadres? It's because Kenya Medical Training College, which is where I work, and that's a picture of the campus in Nairobi, is an old institution. We are actually going towards 100 years next year. So we have been training health workforce for that long. And we are contributing to, it's estimated to 85% of the health workforce. So we train diploma level cadres. So we train nurses, what we call registered nurses, and we also train enrolled nurses. We train the clinical officers. We train occupational therapists, physiotherapists. So what I'm calling middle level is the non-degree holders, and as well as the allied healthcare workers. And we've got very many students. So currently we are about 80,000 students at KMTC across 126 programs, and we are in 90 plus campuses. Okay, so the campus, what I showed you the picture was just Nairobi. We are in every part of the country. So if I was actually to zoom out on this, you would see very many campuses. They're all over Kenya. You can see that a significant number are in the arid and semi-arid. So if you see like the part that's dry on the map, we have campuses there. We have campuses at the top there of Kenya that is called Lodwar. We have campus on the border, that's Mandera. We have a campus in Garissa. We have a campus in Lamu. So we've got campuses in areas that are hard to reach. And in those campuses, we're training healthcare providers or healthcare workers. We graduate a significant number of students, and as you can see there, it's increasing. Okay, so we have large graduations. We have one graduation, and we hire a stadium. For the past 2 or 3, 4 years, we've been hiring the stadium in Nairobi for the graduation, because last graduation we had 23,000 graduates, and if each of them comes with 1 or 2 relatives, which they don't, they usually come with a bus. Oh yeah, they do. Then, we fill the stadium completely, and we have an overflow. So we are really producing a lot of healthcare workers. And as I explained to you, they are all different cadres: medical laboratory technologists, occupational therapists, which are the community oral health providers. So it's a whole range of cadres. What you would say the big three would be clinical officers, nursing, the big two, and then you'd have the others who would say allied healthcare workers. So I just put the purple line because that shows nursing, because nursing is our flagship course. It's a course where everybody wants to do. I mean, we get 4 to 5 times our capacity in terms of people who are applying to join our nursing programs because everybody wants to be a nurse. And I'll tell you why. Because of migration, all right? So there are many opportunities now for nurses to work abroad. And so everybody's dream is to, exactly. It is. So this is from our department that processes transcripts and verifies documents, and you can see it's been steadily increasing. Just this year, they have done, I think, first quarter, 500 requests for documents to be verified because of migration. The important, I mean, the ones that people really are doing are nursing. Those are the programs that are in demand. But there's also physiotherapy, where a lot of people have been going to Germany, to Australia. There are opportunities there. Occupational therapy also. Why? Because populations are aging. So there is a need for people to provide nursing care, home assistance, home care, as well as rehabilitative services. So we're finding that we have people coming in, even to KMTC to ask, you have this course in rehabilitative sciences, what can we do towards migration? We recently had also an interest from a group from Canada about our emergency medical technicians, our EMT courses. Again, we're exploring what's the pathway. Is it possible? They want to know how do we train so they can be able to see how does it align with their training so that there can be opportunities. And of course, the healthcare assistance. So that's a course that we've also started recently because of that. People coming to us, do you have this CADA? We have a shortfall. And so we recently started it. And I've told you the countries where most of our graduates are going to. And it's an exciting time for us and for them. So this is just to showcase how we're doing healthcare training, a health workforce training, but the factors that are affecting other health workforce shortages in other countries is affecting our training and what we're doing. So we have to train, but we have to also recognize that we're not training only for ourselves, but for others as well. So it's our reality in KMTC. So in the context of those, in that context, what are some of the things that we've been doing? One is that we are constantly seeing opportunities to increase training. We're not only increasing our training capacity for Kenyans, but also for others. We've trained for Sudan nurses. We've had a conversation this year with the Angolan Ministry of Health. They have come to look at how we can train healthcare workers for them. Our members of staff, our board and management went to Angola last year, also to have that conversation to see what are the cadres that they are lacking and how can we plug into that, because we've been training for a long time, so we do know how to do that. We've also introduced foreign languages, okay, and you can see the ones that we're doing now. So we are, you can do a short course in Amharic. Remember, we have a border campus at Marsabit that borders Ethiopia. We also recognize that we have Arabic speakers. Our northern part of Kenya has a lot of Arabic speakers, and then also our nurses are going to Arabic-speaking countries. So we've added Arabic and, of course, French and German. And it's interesting that a lot of people are actually doing those courses because they can see the potential and the pathway to immigration. And this aligns very well with what our mission is, which is to be a globally competitive institution. So we are seeing the world and training for that, and then ensuring that it is fit for purpose. So we're very keen also on the fact that we need to make sure that we're meeting the needs of the health market. Another thing that we've done, and I know I've made them a bit small, is that we have a program that we've been running for, I think, 2 to 3 years with the UNHCR. So we recognized that the UNHCR is running runs refugee camps in Kenya, one in Kakuma and another one in Dadaab, and they were finding that they had no opportunities for tertiary education, especially for refugees who wanted maybe to go into health care programs. So the campus that's closest to that is a campus called Lodwar. And so we started together with UNHCR an enrolled community nurse training program, that, which is the certificate course. And so what they do is that they, together with the local government, they shortlist students from that region. 70% are Turkanas. Turkanas are a people tribe that are in the northern part of Kenya, northwestern part of Kenya, and they're marginalized. And they sometimes don't get opportunities to do training, and then people don't want to go and work there. So this offers an opportunity to have the locals be trained in a campus that's close to them, because they will meet the need of that community as well as the refugee need. Another initiative is the Beyond Zero. Beyond Zero was started by the former First Lady, Her Excellency Margaret Kenyatta, and what she wanted to engage with women and issues that affect women, whether it's in healthcare or in gender-based violence or other aspects. So she started this initiative to also train healthcare workers from arid and semi-arid areas. Okay, so they again intentionally go out and shortlist high school students or learners from those arid and semi-arid areas so that they can go back and work there. And this is also an enrolled nurse training. Why I keep talking about enrolled nurse certificate is because the entry level is lower. So one of the challenges in those hard-to-reach areas is that they don't get the resources they need to pass high enough to go into university or to join even the registered nursing. So we had a different level that has a slightly lower entry level that allows for them to enter into healthcare. And they have trained 1,500 in that program so far. And there's a lot of testimonies about the change that it has made, because it's not only that the learner or the healthcare worker is going to work in that community, it's that also their life is changed. They now have a livelihood. And so it makes a big difference. We had an opportunity to visit South Korea and do some collaboration. And what we were trying to do was around building capacity in emergency and critical care. And when we went there to do benchmarking, and we were keen to see how the emergency response, how they set up their system. But when we thought about what kind of intervention can we do when we go back to Kenya, we realized we can't, as KMTC, we have no access to ambulances. We have no access to, we have access to hospitals, but we don't own them. So we thought maybe because we have 90 plus campuses, we could do some community engagement and train first responders. So first responders in Kenya is people, okay? People are the first responders. When you get an accident, the first responder is the person next to you. And we identified the most important first responder in Kenya is what we call the border, which is the motorcyclist. They're always the first people to come into a scene and rescue people. So we then decided to train the borders in our community. So we said each of our campuses, 90-something of them, will train 50 borders. So we last year trained 11,000 borders, and it was a one-day BLS first aid training, and they were very, very keen. In fact, they were so happy with coming to. They felt so glad to be recognized that they play an important part in healthcare. And so these are the motorcycles. They're all parked there as they came to a KMTC campus. They brought their transport. Yeah, and then this is them being taught capacity building. We talked about competence. I think you've seen as a familiar face. Yeah, so I first met Professor Ashti 2023. I was invited to speak at a conference. They partner, Northwestern partners with Maseno University, and they do a health professions conference. And their first conference, I was invited to speak. And so that's how our journey began. We started with Zoom, then we then go on to meet physically. And when she came to Kenya the other day, a few months ago, I told her, you know, we have our KMTC at 100 webinar. So we have these webinars that we are doing to recognize that we're going towards 100. We want to contribute to community and society in terms of knowledge. And so we've got different tracks. So I asked her, would you like to speak at our KMTC at 100? And she said yes. So this is the poster that we did. And was it close to 100? Yeah. Yes, they joined the webinar and they listened to her speak, and it was wonderful. So we're very glad for that. But there's other things in collaborations that KMTC has had, and I just pulled out just a few. One was with Fred Holos about ending blindness in Kenya. So they're building capacity around ophthalmic workers. So nurses, clinical officers, and optometrists, and then there is recently we had global mental health, mental health leadership conference that we hosted at KMTC, that is run by Africa CDC, and there were like 11 countries that came for that conference, and then also there were a significant number of staff at KMTC who joined the conference, and then I think the bottom picture is another common face in Northwestern, yes? Dr. Colleen. So after one of the conferences, I asked her, because she's really good at simulation, I said, can you build capacity for us around simulation? And of course, my background is anesthesia. So these are the lecturers who train clinical officers and nurses in anesthesia. And we are at a campus in Kisumu. And this is the Sim Lab in Kisumu, and she's doing a training, teaching the staff how to do simulations so they can incorporate it into their training. So we're also trying to see how we can bridge the gap around competency. Remember I said about competency is a big problem in Africa and in Kenya? So we're trying to see how do we improve what we do so that we can build competency. I will now come to myself. I've had this question asked, so how long have you been in global health? And I'm like, I'm not so sure I'm even doing global health. But anyway, in 2020, I met a gentleman who was a part of an organization here in the US actually, but he was in Kenya. But it's an American organization. And they had been doing simulation labs in different countries, including Tanzania. And I asked him, I challenged him, I said, you're headquartered in Kenya and you've not helped build us a simulation lab. Can you do that? And he said, yes, I can. So this is the launch of the simulation lab at Kenya Medical Training College. It was launched in July 2021. And we had never had one. I mean, it looks like just the other day. And you're thinking, we've been doing healthcare training since 1927. But this is the time. That was the right time. And we have there the Director General of Health. And the pictures below is some of the things that we've been able to do in that simulation lab. COVID hit immediately, we started that conversation. So we then had to start training hospital-based teams around simulation. So this was in our lab, this was in a hospital, and we've had more than 100 healthcare workers come in for us to teach them simulation, and then to ask them how they're going to incorporate it in their hospitals. I also do point of care ultrasound. I got trained in 2019, and it's been, from then on, I moved from provider to instructor, And there's a lady, oh, she's not in a picture, I didn't put a picture of her, a lady she's an emergency medicine physician called Deirdre Duffy from Canada. And she had this vision of training Kenyans in point-of-care ultrasound. So she came and she trained us as instructors and then said, okay, would you be willing to become instructors? She trained us as providers. Would you be willing to become instructors? So we have been training. Every year we run 2 trainings as part of the POCUS outreach. And it's open to Kenyans, but we also invite other people, Tanzanians, Ugandans. So we've had people from the East Africa region and some Canadians, because she invites them to come for this training in Kenya. And then you also can go to the park, so it's a safari kind of thing. So we do get some Canadians coming for our training. And as you can see here, the bottom picture is instructors, and the 3 in the middle are Canadians. So we do joint training with each other. I've had an opportunity to train other healthcare workers also in point-of-care ultrasound, and then also be part of a technical working group that was trying to see how to use point-of-care ultrasound to reduce maternal mortality. And in my role, I was in a group that was doing the curriculum. So this is a recently launched curriculum in 2024 on obstetric point of care. The Ministry of Health has adopted it and has said we are going to start training and recognizing point of care as an intervention that reduces maternal mortality. So nurses, clinical officers, doctors are being trained how to use it. I also had an opportunity to, join a summit that was also talking about that. So I was asked to give a talk on what role does KMTC play in this conversation around point of care, and I was very glad for that. And then comes to research and health education. So this is us in Kisumu last month, okay? So we were at the 4th, imagine Northwestern has done this for 4 years in a row. This is the 4th Health Professions Education Conference. And the reason I bring this picture is because last year, Professor Ashti asked, can we, and I think there was a proposal, can we do a certificate course for faculty who are training in health to learn how to do it correctly. So there's a certificate that was started last year. It's a 1-year certificate on health professionals education. I hope I've not butchered the name. All right, yeah. And so I circulated the poster to KMTC staff. And these are the KMTC staff who joined and successfully completed. And we're very, very glad, because it then means that we are building capacity to enhance our training programs. And so they're there with Dr. Colleen and Professor Ashti. And then I had an opportunity to mentor 2 students. So I had mentored 3. Those are the 2 who were presenting their posters. Last year, somebody challenged me to begin a community of practice of global health persons. I resisted, then I said, okay, I can try. So we offer courses through a university that's based here in the US. And these are the courses that we've done so far. We are currently doing economic evaluation in global health. And in June, we will do global mental health. What I do is just, send a poster out to people to join, and then we do the course together. It's a 10-week online course. And so these are some of my colleagues who I am happily giving a certificate as they have, completed their course. And it's been very interesting seeing how people are internalizing, and because some of them you have to do projects like policy and advocacy. So I could see people saying, yeah, we need to write a policy brief about this. Some were in ophthalmology, some were in academia. It's really been great to see other people joining together as we do global health in our setting. we've had 110 participants so far. And last but not least, I saw this picture. I feel that we've sort of like gone full circle. This was an article that somebody posted in our family group. It talks about 4 nurses who were taken to the UK in 1961. KMTC started their nursing program in 1958. And Kenya got its independence in 1963. So as the British government was trying to hand over, they wanted to build capacity to take over some of the leadership roles. So they identified some 4 ladies. The first one is my mother, Ruth Gicheru. So she went to the UK and she studied midwifery. And so now when I look back, I see we've come full circle. Now we are sending nurses to the UK who are trained in Kenya to work. So it shows, I think, that over time there's been progress and that we're heading in the right direction. Thank you very much.
Hi, everyone. So we have about 10 minutes or so for questions, if anyone just wants to.
Thank you. That was really fascinating. There are so many questions to ask. I'm like, arid, semi-arid regions, all of these things. But my question is, what about the mismatch of all those unemployed health workers? What's the problem? How does that get fixed?
Yes, that's a health systems question. Okay, do I take up many, Grace? All right, okay, thank you. So that's a conversation. So this was commissioned by it's the WHO and so it submitted it to the Kenya government, and it's one of the conversations that we're trying to have now. How do we make sure that we employ the people that we train? And one of the things, of course, is that you need to put in more money. Now, because health was devolved, employment is not a national issue, it's a county government issue. So you have to keep having meetings with the governors to employ staff, because there is a shortage. So the system has fewer health workers than they need, but there are quite a number unemployed, but they say they don't have the money to employ. So it's a conversation that we're continuing to have. Apart from that, there's a lot of conversation about how do we even match and see who we have. So we've got all these regulators, because every cadre is regulated by different people. And the government is trying to see, can we do a bill? So that is now the bill that they're putting together. How do we put a health workforce policy? How do we merge this everybody together under one umbrella so that we know who we have, we know who's unemployed. So the government is making tracks, but they just need to find money to employ. Yeah. And then with funding being cut, external funding, so that affects employment significantly. Yeah, a lot of people lost jobs when USAID funding ended because they were in malaria, HIV projects, TB.
Yeah. Thank you for the very insightful presentation. And my name is Emmanuel. And I'm from Nigeria, so a lot of the things you talked about reflect back on what's happening back home. But quite interesting to see that you have a central training institution. I found that quite intriguing. It's engaged where we have multiple training institutions back home and in many other countries. So I think that's a big, I think it's quite innovative and I kind of like it. So how do you really manage that centralized structure? And related to that, what's the funding model? How do students get funded to be on that program? And then what are the alternative training institutes you have? Is this the only one since it's centralized? And then lastly, what do you do to mitigate or prevent or delay migration? Thank you.
I will start with the last one. we are not mitigating, preventing migration. And I don't want to say unfortunately, because they are unemployed. So you cannot tell them not to migrate. It's almost inhuman not to do that. And government anyway has sanctioned, has allowed that they can migrate, so there's all these bilateral agreements. So migration is, we're I don't want to say we're migrating, but yes. I don't think you can stop it. But I think the thing is, how do you retain or attract? I think that's the thing that governments need to think about, because people want to work as healthcare workers, so, and that again ties in with the conversation, what I said, that we just need to pump in more money, improve healthcare, in terms of people feeling that they're being utilized, not underutilized, so that they can feel that they are gainfully employed and enjoying what they're doing. KMTC is a government-owned institution, so under the Ministry of Health. But there are others that are faith-based, that are TVET. TVET is tertiary vocational education training institutions, who also train some of the cadres, like medical lab and all. So we're not the only ones training at that level, but we are the government one that trains here. And then funding for students, again, they pay school fees. So it's parents that fund generally. But the government also funds us, because they recognize that we train a lot, so they also give us a significant amount of money to be able to run the institution. And then there's loans that are available to students through funding that they can apply for as well, and bursaries as well. County governments actually are quite good at doing that. So like in those marginalized areas, they actually pay school fees for those students because they know they're going to work for them. So they also fund it that way. And I think that was the last one, or did I got all of them? Okay, thank you very much. Yeah, I'm amazed at my...
Hi, my name is Ariel. I'm a PhD student here. Okay. And thank you for your presentation. It was wonderful. As an aside comment, I feel like high-income countries need to be paying Kenya if you're going to be training some of our personnel and we reap those benefits, but that's a complicated thing, but I think we should work on that. But my question, I did have a question about retention and how to kind of help keep people in country. I agree that I think attracting people, and when I lived in Rwanda, oftentimes the ministry would think about like a package, not just what can we pay the health professional, but like, could we provide a car? Could we pay school fees or housing or something else to kind of supplement within our means? But since that was covered, my question is, oftentimes with NGOs and even faith-based organizations or private institutions, there are certificate programs, there are, very well-intentioned efforts, but I had an opportunity to live in Zambia and did some work in rural areas, and you'd find people would say like, oh, I have this certificate from this NGO, but it wouldn't mean anything in the country context because it was maybe not recognized by the Ministry of Education or the Ministry of Health. So I'm thinking in this room of people that are probably in like master's programs for public health, like what would you advise, personally and professionally, for people who find themselves in an NGO at some point or in a more private setting, who want to do a training, have really good intentions, but don't understand maybe that there's a whole complex structure? Because otherwise you leave a person with a piece of paper, and that's not okay. Yeah. So I'm curious about your thoughts.
Yeah, absolutely. And that's where we started with the point of care ultrasound, actually. So we were trained, we have these certificates in point of care ultrasound, but you go into your institution and they're like, oh, we still need another ultrasound. I'm not sure that we're going to base our clinical decision making on what you've done. So when the government came on board and said this is an intervention that helps reduce maternal mortality, and actually came up with a curriculum, now everybody is doing those certificates because they recognize that in the workplace, the institution is going to see that it is contributing significantly to our outcomes. So I think in global health, we just need to do a lot more advocacy, and we just have to do that, especially if the training, when we're doing like CPD, professional development courses, you have to really keep showing what difference it's making amongst the people that you're doing. And then for institutions, I know like for us when we did the certificate course, one of the things I kept telling the students or the participants is, please make sure we need a critical mass. We're going to go to HR and say we've done this training and it is important and it needs to be recognized. So also at workplaces, we also need to do that. Because we do appraisals, it can be something that's added to an appraisal and show that you've got new skill sets. And therefore, perhaps it then allows for you to get a promotion or something. Yeah, but you have to do a lot of advocacy, yeah.
Hello, my name is Oyin Ajala. I'm also from Nigeria, and I work at Bola Center as an epidemiologist, and I'm a DRPH student. I wanted to learn a bit more about the transnational issue that you've been able to solve, which is the Butter program. And I wanted to learn what were the issues that you faced in trying to implement a program like that. And also, like with recruitment and things like that, was it more on their side? Were they interested, or did you have to do like a lot of work to recruit people? And also, how do you plan to scale this program? Because I can just imagine something like this would fly very well from my country. And just if you could talk about that a little bit, and if there's any website that we can learn more about that program, I would be very interested to know about it. Thank you.
All right, thank you. Unfortunately, there's no website. Because we started it as one of the ways to start to have the conversation around our emergency medical services. In our country, we don't have an organized ambulance system. So, and a lot of hospitals have ambulances, but they don't use them to come and pick you from wherever you are. They will use it to transport you from one place to another as a patient within that hospital. And then there are very many players in the ambulance, very many ambulances that are owned by individuals. So we found that was a difficult one to address, but we wanted to do something at that level. So when we looked at it, we said we can probably engage at the bystander level. And we recognize that we, as KMTC, have a connection with community because we've got campuses in every part of the country. So if even in that community, if somebody got an accident and the border guy can be able to do something, because they would carry people arms and hands up and your head is lagging behind, so you're kind of like, okay, I know you want to respond, but at least let's show you how to do it right, without minimizing injuries. So that was what our intervention was. It has gained a lot of traction. We funded it ourselves because all they wanted was the loss of income. So we just paid them for their morning that they lost income. And it wasn't a lot to the institution. It was just 1,000 Kenya shillings, which is less than $10. I mean, it was not much. So it's something that's doable. But the more interesting thing was now we have this community who are willing to engage around emergency response. And perhaps it can be a movement that changes something within that county. Yeah, so feel free to adopt it and do it. Yeah. Yeah.
Thank you, everyone. We're going to do like a 2-minute reset for our next speaker. If you need water or anything.
Thank you very much.
Dr. Gicheru, thank you so much for sharing your expertise with us this afternoon. I'm Bill Leonard. With Ashti, I'm co-director of our Center for Global Health Education. And it is my great pleasure to introduce our second speaker for today, Dr. Jennifer Morgan, assistant professor in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. Dr. Morgan is a medical oncologist with particular interests in the impact of melanoma and breast cancer globally. Her research focuses on improving cancer care delivery in resource-limited settings, both in sub-Saharan Africa and in the United States. She has done research on cancer care in Rwanda, Malawi, and Kenya. Dr. Morgan's work has also been well supported by a number of agencies, including a Fogarty Foundation Global Health Fellowship, an AIDS Malignancy Consortium Scholar Award, and a Young Investigator Award from the Conquer Cancer Foundation. This is a bit of a homecoming for Jennifer, as she did her residency in internal medicine here at Northwestern and was part of our McGaw Global Health Clinical Scholars Program in 2017. Today, she will be sharing her experiences with us on working towards global oncology equity through partnership. Please join me in warmly welcoming Jennifer Morgan.
Thank you so much. I'm so happy to be back. It feels very good. It's been about 7 years, so this does feel like coming home, so it's really nice. Today, I really want to talk about my path in global oncology, and I really feel like that started here for me, and so it's very timely that I am here and talking about that because of many of the early opportunities I had here at Northwestern. So I want to talk a little bit about my background, these opportunities that I had to train in global health here at Northwestern and after, and what I learned in those early opportunities. And one of them that I've carried with me all throughout my journey is the idea of accompaniment of patients and providers in other health systems, and how that translates into really academic global health partnerships. And then I'm going to focus on my current work in global oncology, particularly in breast cancer in Kenya, as part of the AMPATH Global Health Partnership. So a little bit about me. Like some other people in the room, I graduated with a degree in anthropology. I was always, from the University of Michigan, I was always interested in people, in culture, in interactions, and really the underlying premise that people are quite similar everywhere, and that health is a human right. I went to medical school at Michigan State, and then I came here to Northwestern for my residency. And after some of those experiences as a global health clinical scholar, I stayed on for 2 more years here in the Division of Hospital Medicine while also working in Rwanda with Partners in Health. That really fueled my interest in oncology, and I went back to fellowship at the University of North Carolina to really get my degree. And then I've had 2 faculty positions, the first at Indiana University and now at University of Minnesota, in which I would consider myself maybe as an early global oncologist. And so one of the first opportunities I want to talk about is when, as a 3rd-year resident here at Northwestern, I went to Chiapas, Mexico. And my interest in global health was really growing at that time. And Partners in Health, which I'll talk about, had put out a call for senior residents to go and mentor pasantes, which are young career Mexican physicians. They really had only graduated with an internship, and then they were tasked with a social service mission. So they went to a community, and they had to provide all of the care for that community. So their training was minimal, and they really benefited from the mentorship. So I approached Ashish Didwania, who was the program director at the time, and he said, I don't know about this. And eventually he said, if you write the memorandum of understanding and you learn something, you can go. And so with the support of Ashti and Shannon, we wrote the memorandum and we went. And I think this experience at Partners in Health really changed the way I thought about global health. And I made a poster about my experience that I posted up here from 2017, like many of you did today. And I really evaluated the role of community health workers in chronic disease management in Chiapas.
We interviewed them. We learned many things about their role accompanying patients throughout their chronic illness journey, and some of them had cancer. I learned about the role of accompanying patients, and that was long-standing. There are communities all over the world that have functioned as community health workers since the 1950s in Tanzania and other parts of South America, that people had been doing this and recognized the need to walk alongside patients as they really go through their illnesses. And that's the kind of doctor that I wanted to be, and that really was instilled in me from an early point in time. And so as part of this experience, I got an introduction to Partners in Health. Many of you know this organization. It's I would say, a social justice organization that is based in the fact that healthcare is a human right. It started with community health workers in Haiti, mainly around the HIV epidemic, and grew all over the world. And one of the central tenets is this idea of accompaniment. Paul Farmer, one of the founders of Partners in Health, is famous for talking about accompaniment, which he did steal from liberation theology, but also I think it was very timely in healthcare. And I like this quote that he said is, accompaniment is an inelastic term. It has a basic everyday meaning. To accompany someone is to go somewhere with him or her, to break bread together, to be present on a journey with a beginning and an end. That's an element of mystery, of openness, of trust and accompaniment. The companion, the accompagnateur, says, I'll go with you and support you on your journey wherever it leads. And I thought, and over time I've thought about this principle and what that might look like in a healthcare system. And that means accompaniment is really care centered on the caregiver's responsibility to their patients over long periods of time, hopefully. That can look like community health care workers who support patients through chronic illness. Maybe that's pill counting, maybe that's moral or psychological support during that time period. And it's also support for the people who take care of sick populations, so physicians, nurses. And I think that can manifest as an academic global health partnership. And one of the other tenets of this, as you walk along a journey with a patient, is this idea that you reject resource scarcity as a justification for inadequate care. And I think that's really profound, is that if you are working to accompany someone to give them the best health, you will not accept that, and you will fight for that. And some people maybe call that unrealistic or economically infeasible, but I think it's a way to change healthcare and is an important concept. So after I graduated my residency, through the connections with Partners in Health, I went, and through the support of folks here, I had a position where I was a hospitalist part of the time, but I spent most of my time in Butaro, Rwanda. So this was a cancer center. The Butaro Cancer Center of Excellence opened in 2012, and it was really testing a new concept. Oncology, a very high resource field. Many of you may know oncology drugs are very expensive and treatment is intensive. Many people thought in global health, this can't be done in a low resource setting, and it certainly can't be done in a low resource rural setting. It had been done in capital cities that tend to sequester more of the resources, but it hadn't really been done frequently in a rural setting. And so this model did a few things. It had the academic support of a North American institution to kind of offer some of that specialty support. And they used a task shifting model because at the time there were very few oncologists in Rwanda. And so the task shifting model said, well, we'll have internists, Rwandan internists mainly, and some North American internists treat cancer because they're equipped to treat protocolized cancer. They can follow a protocol. the basics, and if they have any questions or concerns, they can meet with an oncologist to go over those. And lastly, it developed really important priorities in cancer care. And I think this was, for a first-time rural cancer center, it was very practical priorities. So number one, let's treat cancers that we can cure, and let's prioritize that. And so literally there was a list of cancers that were, highest likelihood of cure, and that was the priority. And then to also implement a palliative care initiative, because we knew that so many patients presented with advanced disease. And so I was there really on and off for 2 years, and I worked alongside Rwandan internists treating oncology patients with all types of cancer in this rural setting. And we delivered chemotherapy, we referred to surgery, some targeted therapy, and we met every week with a Dana-Farber oncologist. We went through the complex cases and discussed them. And then we really did quite a bit of embedded research within this newer program. This, even just showing you, it's a long trek up from Kigali to Butaro on a muddy road most of the time. And all of us took that trip every week. And the lower picture shows something unfortunately uncommon. I think this was an osteosarcoma, just showing the frequency of advanced disease that we saw. And some of the really interesting research that I was involved in surrounded around chronic myeloid leukemia, or also known as CML. And CML, if you get that diagnosis in the United States, you live a normal lifespan. It's actually quite amazing. But if you cannot get access to those drugs that can give you the normal lifespan, the targeted therapy known as Gleevec was the first drug that was created. Your lifespan is only a few years. So it really is a huge difference upon having access to these drugs. So there was a program that was formed by the Max Foundation known as the Gleevec Patient Assistance Program. And if you could prove that you had CML, which was the kicker, if you could prove, you could get access to the life-saving treatment. So the question was, how are you going to prove that you have CML? And so because of all of the HIV and TB work with PEPFAR and all of these organizations throughout the continent, there were many gene expert machines that test PCR. And fortunately, those machines could be reprogrammed to detect the mutation, BCR-ABL, that gives you a diagnosis of CML. So these gene expert machines were reprogrammed to test for CML, and we were treating CML at Butaro. And together we published a study of 10-year outcomes, in which our outcomes were still not that great, even though we had access to the drug. And you can see here, it's really based on your response to the right, but few people were living anywhere near the lifespan that people do in the US. And part of this study helped us to advocate for the next line of drugs and the third line of drugs, which eventually came to Butaro and can lead to better outcomes, this was an example of how we had a resource-adapted oncology intervention, how we evaluated the program through research and advocated for something better. And this is a process that I learned in Butaro and really got me excited about doing the oncology work in the region. And so with this, I decided to go to oncology fellowship at that point and was really excited about that. I went to and so just a few more about the conclusions from working in Rwanda. I think a few points really hit home for me. that oncology care can be done in a low-resource rural setting. And we can really evaluate these systems through research and advocate for change. And that academic partnership can be a form of accompaniment for our patients and providers. And that global oncology, kind of this idea, what is global oncology? The idea that working in oncology in limited resource settings as a partner can be a career path that you can do. So I went to fellowship at the University of North Carolina, and I really joined an amazing team of people. I was able to do a Fogarty Global Health Fellowship, and I met Dr. Temiwe Tomoka. She's a Malawian pathologist who really helped build the program at UNC to develop the pathology capabilities to diagnose and treat cancer. And so she was very inspirational to that work, and she really advocated to do breast cancer, a very common cancer, and in Malawi where women do very poorly. And with this and the idea that we wanted to evaluate the breast cancer treatment system, I gained some dedicated training in implementation science. I do have our team listed here on the bottom that we worked together for a few years. Dr. Temiwe Tomoka is there, myself, Dr. Takondwa Azuze, who I think just finished her oncology training in South Africa, the late Shakina Elmore, who was a radiation oncologist, and just a huge advocate for cancer patients herself, and Lucia Simwinga, who's also gone on to do oncology fellowship. So that's been very exciting to see, because at the time they were medical officers and now have gone on to undergo specialized training. And so what we did, and using this model of looking at the treatment system, evaluating it, and then advocating for a better system. And I saw this work today in some of the posters, some of the implementation science research in practice. And this is the same thing that we did in Malawi. We looked at the treatment patterns, the response, and the outcomes, and we saw the gaps. We knew people were not completing treatment and that they were presenting with late-stage disease. Those were really the two take-homes. So we did a lot of interviews among patients and providers. We did qualitative interviews looking at what were the issues in the system and how can we actually facilitate treatment. I talked with, I think, someone today in the poster session. One of the big things that we found in barriers to care for women was the stigma of cancer itself. In Malawi, HIV had reached very high rates, in the decades prior, and had actually become destigmatized. And so we found women who were HIV positive with breast cancer had been living in their communities without any issues, and then when they got the diagnosis of cancer, became ostracized. So it's a very interesting concept of, I think, what stigma is, how it evolves over time. And we certainly were surprised to see that. And then we began implementing new interventions to improve the treatment system. So for us, this was, how can we diagnose breast cancer earlier? And so we, like you, use point-of-care ultrasound to help diagnose breast cancer earlier. And so from that work, I was fortunate to get my first faculty position at AMPATH. And so AMPATH stands for the Academic Model Providing Access to Healthcare in Kenya. And so this partnership involves Moi Teaching and Referral Hospital and Moi University in Eldoret, Kenya. So this is all in the western region of Kenya. And they partner with a consortium of North American universities. So you can see all of these universities are listed here. So it's not one university, it's actually many. And I would say each organization picks off kind of its expertise or where it wants to partner. So Duke in cardiology, was very prominent in IU and infectious disease and so on and so forth. So it brings together a bunch of universities essentially into a common place where they can, I think, understand the shared values of the organization and work in that space. And so this is just an example of the oncology branch, which when I was at Indiana University, this is where I focused. And so our mission in working at Moy Teaching and Referral Hospital was to focus on improving the clinical care, education and training, cancer research, and how to implement this at a community level. And so our approach was broad, and they, as Ampath Oncology, they had agreed on a number of core values, which I think is very important in a partnership. And the idea of service with humility, the idea that the partnership should be based on mutual respect and that there should be mutual benefit. So North Americans, for example, do not have all the authorship, and that Kenyans maybe who have a different structure of promotion are going to benefit from the academic work in the group. For example, that was a big part of mutual respect, mutual benefit. And then really having a strategic partnership with the Ministry of Health so that the work that we do could be translated into policy and affect real change. And then how, as always, how can we make the interventions that we do sustainable? And so as part of Ampath Oncology, we have big teams of people because it takes a lot of people to work on cancer care. Right front and center on the left is Dr. Neftali Busakhala. That is my main collaborator and who I work with the most. And we have a large team of nurses and research assistants who also have worked with us. Up on the left at Webuye Hospital, we were doing a breast POCUS intervention there, which was a large training. And if you see on the bottom left, we brought over a breast radiologist who could offer specialized training in breast biopsies and a variety of other procedures that she trained actually radiologists in because they did not receive specialized training in breast radiology. And then up to the right is one of our cohorts of kind of the whole group together. Actually, and I'll get into this with our team from Nepal as well, some of our partners there, Kenyan partners, some of our North American partners, and just some of our core group here down on the right who is doing kind of the hard work of seeing all the patients, doing all the ultrasounds. As a team, you get very close. And so Ampath Oncology, Dr. Patrick Lair on the North American side and Dr. Neftali Busakhala on the Kenyan side really formed this coalition about 20 years ago. And I think this is just an example of the incremental change that you can make in an academic partnership. So in 2001, there was no national cancer registry in Kenya. There was no national screening plan. There was limited radiation units, so there were 2, and there were few oncologists in the country. They were in Eldoret. They were giving some chemotherapy outside, actually under a tent. Was really the only form because they did not have a designated space. And in 20 years, the care has really transformed there. It's pretty unbelievable. So first of all, this $5 million Chandaria Cancer Center building was built with the money from a Kenyan donor. So that was very exciting. That obviously this was not money from outside the country. This was Kenyan owned and built and prioritized. And then they used a linear accelerator, which is the standard of care for radiation. They built a chemo suite, and they treat more patients than we do at my clinic in the US per day. They see about 150 patients a day, at least 50 for radiation. So the numbers were really large and showing that efficiency that they could get people in and people out. And a lot of this came obviously from individual funding, but also I think the strength of the partnership and the belief in incremental change. Now there are 10 new medical radiation, peds, and gyn-oncs. There is the gyn-onc fellowship, and they've graduated over 14 fellows, I believe. There's a oncology nursing curriculum, peds onc curriculum, and a new med onc curriculum. There's a number of fellowships and a number of research grants. And so all of that has really gone into building an oncology treatment system over about a 20-year period. And so what our focus has been, and I came on the tail end of this large screening program, was how do we do breast and cervical cancer screening? These are some of the most common but highest mortality cancers among women. And so we wanted to evaluate this large-scale screening program. And so we were doing clinical breast exam amongst women, and then VIA, the visual inspection with acetic acid, for cervical cancer. And the goal was to screen people for those cancers. It was not a designated co-screening effort where they made sure that women had breast or cervical cancer screening. And over a 5-year period, they screened 113,000 women in Western Kenya. So the numbers were quite large, and so the reach was huge. And what they found is that most of these were young women who had never received screening before. But 56% of the women received co-screening, showing that in large numbers, you can co-screen women on the same day. And this bundling of tasks could be done in order to offer both services to women. Still, the diagnostic cascade was a challenge. And so breast biopsies were unfortunately not done at a rate that, an acceptable rate, and there were many women who did not get the necessary breast biopsies, and that was really a learning point from this. But we did find that even through the COVID pandemic, the numbers stood, and it was sustainable to recruit patients even through a global pandemic. And so off of this, and this challenge with breast biopsies and completing the diagnostic cascade in breast cancer, we created a breast point-of-care ultrasound program. And we tried this out in E10 and Webuye, two kind of county-level hospitals in Western Kenya. And we wanted everything to be done on the same day. And so we trained 8 sonographers who were doing breast ultrasound, but really had not received designated training in breast ultrasound. So we had them do a 2-week intensive course and a 3-month online course with a team of breast radiologists from Indiana University, as well as our MOI teaching and referral radiologists. And in that time period, they showed significant skills acquisition on the pre and post tests and high concordance with breast radiologists. And so certainly there were skills gained there. And mostly the other thing is that we wanted to see that we could do same-day services to retain patients and ensure that they get the diagnoses they need. And so after all of this work, we really wanted to expand the work we were doing in 2 different ways. So number one, we knew that clinical breast exam, so palpating the breast to do breast cancer screening, was not that effective and is limited. And we wanted to see how we could implement imaging, so breast ultrasound and mammogram, to improve the diagnostic accuracy. So that was step number one. And then we wanted to support patients better so that we reduce loss to follow-up. We knew that that was an issue from the first iteration. And so we also, at the time, AMPATH was replicating its model in other countries. So this Indiana University Kenya partnership, Mount Sinai in New York was now doing with Nepal, And NYU in New York was also now doing with Ghana, and University of Texas is now doing in Mexico. So they were kind of replicating a similar model. And in Nepal, they really wanted to also begin screening for breast and cervical cancer. And so not only did we kind of expand the program in Kenya, we started working so that the Nepali group could also start a breast and cervical cancer screening group. And the last thing we wanted to do was to create an educational model that was a little less North American, Kenyan, kind of back and forth straight line. And we talked about a triangular partnership where we had two different organizations that were in a more resource limited setting. And so the back and forth was more there between the two organizations who were implementing those strategies. And so that back and forth had been extremely educational. And we did pretty large Project ECHO initiatives to teach both on the Nepali side and the Kenyan side. And our Kenyan team went to Nepal, and our Nepali team went to Kenya, and it was really wonderful to learn from both. We learned that what works in Kenya does not work in Nepal. For example, just one example is that to recruit women to get screened for breast cancer in Kenya, radio is more effective. In Nepal, they do not use radio, and actually print is more successful to spread things throughout the mountainous communities. And so hearing that back and forth and trying and taking that idea and refining it and moving it back and forth was really interesting over the course, and we've been doing this for about 2 years now. And so through all of these experiences, I think in oncology, there is still a lot of work to do. And I think where we're really headed and has been more of a focus of mine is focusing on getting access to the bedrock of oncology care, which is clinical trials. In the United States, clinical trials is really embedded in all of the care that we give to oncology patients. And these are nearly non-existent, really pretty much on the continent, especially of Africa. So we wrote this piece about how to improve access to clinical trials, how to reduce the regulatory barriers, and how to design trials that are not convoluted, that don't have too much data collection, and that have meaningful endpoints for patients. And so that's really what we're working on now, and I think we'll maintain, work toward more global oncology equity over time. So I think to close up, I'd say that many of us will have a winding path in global health, and we will learn things along the way that will stick with us and can form a career. I think accompaniment of patients and colleagues is essential to what we do, and that we should facilitate partnerships that are built on shared values and should not be afraid to keep reevaluating over time. What works for your partner in year 2 or year 3 may be different over time. And to be having those conversations, and that incremental improvements over time can lead to big change in a system like oncology. I wanted to say thank you. My family's not here, but they have been with me along the way, my husband and my 2 kids. And I'll take any questions.
Hi, thank you so much. My name is Natalia, and my question is how, from an ethical standpoint, was the message communicated to the community that the priority should be treating curable cancers, especially when many families were watching their loved ones suffering? So I'm just curious, how was this conversation, and what strategies or tools did you guys use?
Yeah, and I guess to get into more of the details is that was a resource priority. So, you know, the focus was on giving chemo if it was curable. We did give chemo, for example, in incurable cancers if it could prolong your survival. But if it did not, that they did not have the capacity to give it. And so I think that was the discussion, is that, you know, we could give all of this chemo, but people haven't lived any longer. It's a complicated discussion. And I think people understood that, especially, I think, in systems where financial constraints are number one. I think people understood that this is not curable, and that we can't give you a treatment that's going to help you live longer. Then I think for the family, they understood that because financially it was otherwise going to be very challenging. So obviously supporting with palliative care, just like we do in the United States and, you know, everywhere else, was huge. At the time, there was a nationwide, I think, morphine program that was initiated so that people had access to opioids, pain medication, and that was coming up alongside and really integral to keeping people comfortable. But I think the idea of palliative care itself was newer, of, okay, we are trying to keep you comfortable, you know, was a whole discussion, yeah.
Hi, thank you so much. I loved your presentation. One thing I was really curious about is, first, there's the idea of the triangle. Sometimes you hear about like a north-south collaboration, and increasingly, I know I worked in Rwanda under Agnès Bengoa. She'd often talk about like a south-south partnership, and I love that it was kind of a combination of the two, like a north-south-south partnership, although obviously not always south geographically, but just a really nice reminder that like it does not have to have a certain kind of hierarchy. So I was curious a little bit more about that, how that idea could spread more. And my second question is thinking about, so I'm an oncology social worker by practice, and oftentimes I found that from a funding perspective, patient navigators, psychosocial support is often, like, unfortunately, one of the first to go when funding gets tight. But is there any thoughts for, you know, maybe thinking of like a business model, like a case study, kind of thinking about if we're going to, you know, bring this oncology medicine into the country, we're going to put all these resources together to bring the medicine to the person. And then if they get lost to care because they couldn't afford transport, like all of that money towards the medicine was kind of wasted. So I know obviously Paul Farmer thought a lot about social packages, but how would you advocate for more funding towards those kind of psychosocial supports? Thanks.
Yes. So your first question, or a little more about the triangular partnership, I think, you know, oncology is a specialized field, number one. And so one thing that we have that is unique is this highly specialized subspecialties. I'm a breast oncologist. I see breast cancer and melanoma, and that is it, you know, and that's common in the US. And so I think what North Americans sometimes can offer in a partnership is that specialized expertise and that training and that transfer of knowledge if you do not have access to a breast oncology fellowship or a breast radiology fellowship. And so I think that's really understanding your role in the partnership is very important. And as we were thinking about what we want partnership to look like and what voices we want to be loudest and where the kind of the impact is, I think we thought about triangular partnership as, okay, we want, you know, I don't live in Kenya. I didn't grow up there. I am not an expert on the Kenyan system, and I recognize that. I'm more of an expert in breast cancer, and I can provide that. And so as we were thinking about our roles with adding more people, we said, okay, the Nepali folks are experts in their health system and how to research adapt their approach. The same with the Kenyans. And and we think that that conversation back and forth is the most important. And the North Americans don't have a ton. They can listen and learn and take a lot back from that. That's where they can learn. But really where we could offer things was in that specialty care. And so I think in acknowledgement of that and where we wanted most of the conversation to sit was how that was created. Because sometimes then just the nature of culture and how people talk and in rooms and who can typically dominate North Americans, there were, I think that was the thought of being in these rooms for a while and noticing those dynamics play out. So that was the first thing. And then I think we absolutely need more patient navigation. It has been on and off done really well in the United States. What has worked in Kenya is having survivors function as navigators. And unfortunately, many of those navigators have had to go unpaid, and they go based on their own just powerful spirit and passion. And we have tried to find ways to pay them, but I find that they are the biggest advocates in their community. A breast cancer survivor who has undergone a mastectomy and can go and tell other women that it's okay to get a mastectomy and you can move through it, for example. It's just one example. That's best to come from them. So I think the survivors are a really huge place, and if we can employ them, we have done that on our grants, and if we can do that in a more sustainable way, I think that's really important. And then community health workers, people who go house to house, who know their communities, I think they're most effective. In Nepal, they have, because of the terrain, they have these really tight-knit communities where they know every house, how many women are in it, and they really have a strong social network that way, mainly because of how the country is situated. And we learned a lot from them that, they have, their follow-up rates are unbelievable. And then in Kenya, where we were struggling just because the communities are bigger, and so it's not as easy to keep track of every single person. But it's aspirational, and we learned some kind of things about how they do that. So I think personally that using the survivors, employing them, they're very excited to do that work, and finding ways to advocate at the ministry level to employ those people for the work that they're already doing is huge. Yeah.
Thanks so much for a wonderful talk. You've had a really impressive range of global health experiences in terms of outreach, in terms of partnerships, both geographically in terms of the range of places, as well as different global health outcomes. Could you perhaps reflect on the changes that you've seen over the arc of your career, and what things are we perhaps doing much better, and where is there still room for improvement?
Mm-hmm. Yeah, I think we are doing much better with recognizing that we need to train people in their home country to get the training and do the work. I think there was definitely an era of global health where it was a lot of North Americans coming and doing the work, and I think we're beyond that, I hope, and where we're training folks to stay in their home country and be the expert. And I think the question is, it becomes, can we train people in their country so they do not have to leave? And so we've been working on that. And so on creating fellowships, I think that's, I'm glad, I think we're beyond that part, but we really need to work on in-country training and educational programs that are sustainable, especially for specialized fields like oncology, where the rates of oncology are really expected to go through, or of cancers are really expected to go through the roof in the next decade. So I think that is improving over time, and we continue to work towards that. I think general knowledge of breast cancer especially is improving all the time, but we still need, I think, large education programs that cost a lot of money to get the word out. This happened in the United States, where there was billions of dollars were spent on breast cancer education, and now we have a community, a society that says, hey, go get your mammogram. You need breast cancer screening. 1 in 8 women in their life are going to have breast cancer in the United States. It's incredibly common. And so we need those big educational campaigns. And something I didn't talk about, one other thing that we're doing is really creating these large radio campaigns on breast cancer awareness. And that's a passion project of Dr. Busakala of trying to get the word out. So I think that's another place where we really have a lot of work to do.
Hey, I'm Amanda. I'm an internal medicine resident. Thank you for an amazing talk. I have a couple questions. The first is, what would be your recommendation be for somebody starting out in the field with like a general medicine background who's interested in global health? Like, you've had a very long, successful career, and it's super impressive and inspiring. And then the second is, how do you balance your role as an academic specialist in breast oncology and also participate in this myriad of international work where sometimes there's a little bit of a discrepancy between the care that you're seeing in your daily clinic and then what you're able to provide with your patients internationally?
Yeah, I think number one, having some experience where you understand kind of the constraints of a different healthcare system, whatever you can do to kind of understand the basic premise of how those health systems work. You'll never fully understand it unless you were born there and grew up in it, but I think that might be living in a place for a period of time, to understand what those health systems are like, because they are very different than the U.S. healthcare system. The U.S. healthcare system has pockets of challenging care, but in general, the dollars spent and the availability is unique. So I would say spend time, I think there's a new global fellowship. It's here. It's essentially what I did, now formalized. There are other fellowships that are more formalized. I know the HEAL Fellowship too, where you can gain that experience, and really you're just understanding how those health systems function to some degree. I think that's probably, and thinking about it from a health systems perspective. And so some people get a master's in public health along the way. I think understanding those systems is what you don't have. You have a lot of good medical knowledge coming out of a medicine residency. You can get subspecialty training that makes you very much know exactly what to do for that particular, in my case, cancer. But what you're lacking is a health systems knowledge, and frankly, learning how to work in partnerships with people that are different from you, from different backgrounds, have different priorities, and having those experiences, I think, gives most people the humility and the understanding of how to work in a partnership. So I would say do that experience. And then how do I manage, having a clinic in the US and doing all this work? Having lived in Kenya and Rwanda gave me the background, and, I prescribed chemo every day, and I did those things, and I knew some of the challenges that helps me kind of navigate the work that I do with my partners, but I still lean on my partners a lot for the knowledge of what the barriers are. I don't live in Kenya, so I don't know the day-to-day challenges. I don't know that this HIV program got shut down, and that was actually referring a lot of breast cancer screening patients. I don't know that, and so I rely on them, and I kind of take a step back, frankly, that, you know, my role is to help in research and specialized breast cancer care, and I rely on them as the experts of their health system. So I think mentally it can be hard to balance an oncology practice where we spend $20,000 in an infusion versus what's available in Kenya. But that's why I try to do the work that I do, because I think that discrepancy is not right. So I think where you live should not determine if you live or die. And so if we work toward getting that access, if some of this work that we can do can evaluate the systems, recognize the gap, and move toward improving that, I think that's why we do it. Yeah.
Thank you. Thank you for that great presentation, actually both presentations. My name is Harriet. I'm a nurse at Lurie Children's, and I've done a lot of global health work on my own. And I really appreciate the emphasis on the accompaniment that you talked about, as well as the education of the people. I think that when we go into another country, we need to meet them where they are. We need to understand where they are, and we need to help educate. So to help destigmatize things like breast cancer. I've done a lot of work in Uganda with a primary care clinic, and we routinely see women in the advanced stages that can tell us how long they've had something, but they just didn't do anything about it because they just weren't sure that they should. So I think that education that we do at the level of our clients, our patients, helping them understand in a way that we understand, and again, destigmatizing what they might see as an issue. You're right, I routinely ask my clinic, do you know your HIV status? Which, to ask that of somebody here would be like, excuse me? They don't even blink an eye. Of course they know their HIV status, but they have not come to the doctor for 6 months for this growth that they've had. So education of the clients that we care for is so important, and thank you for bringing that up.
Fantastic. Can we please have a round of applause for our two extraordinary speakers today, Dr. Morgan and Dr. Gicheru.